Good afternoon, everyone, and welcome to today's webinar discussing obesity treatment and its impact on associated outcomes in African American populations. I'd like to thank you all on behalf of the Council on Black Health, formerly known as the African American Collaborative Obesity Research Network, and the Center for Diabetes Translation Research at Washington University, St. Louis, for your participation this afternoon and interest in this topic. During the presentation today, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to also use the chat window to interact with fellow attendees during the session this afternoon. Today's presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. Today's session will explore the high prevalence of obesity among African American adults in the U.S. population. While obesity treatment is generally challenging, African Americans may face additional challenges in pursuit of effective treatment options. This presentation will review what we know about the effectiveness of obesity treatment and its impact on associated outcomes in African Americans. My name is Sheldon Oliver Watts, and I will be your moderator today. I am the National Director of the Council on Black Health, also known as the Council. The Council is the new identity for the African American Collaborative Obesity Research Network, a collaborative network of scholars and community-based research partners located in over 20 different states. The Council's mission is to develop and promote solutions that achieve healthy Black communities. Our national office is located at Drexel University's Dornsife School of Public Health in Philadelphia, Pennsylvania. The Council leverages the credibility and perspectives of Black American researchers and research partners to facilitate more relevant, community-engaged, high-impact, actionable solutions that positively impact Black communities. I'm also the core manager of the Solutions to Diabetes in Black Americans core at Washington University's Center for Diabetes Translation and Research. As a disparities core, we provide methodological and content expertise to develop innovative approaches that advance the field of diabetes research in Black Americans. Our respected speaker today is Dr. Jamie Ard. Dr. Ard is a professor in the Department of Epidemiology and Prevention and the Department of Medicine at Wake Forest University Baptist Medical Center. He is also co-director of the Wake Forest Baptist Healthy Weight Management Center, directing medical weight management programs. Dr. Ard received an MD and completed internal medicine residency training at Duke University's Medical Center. He also received formal training in clinical research as a fellow at the Center for Health Services Research in Primary Care at the Durham VA Medical Center. Dr. Ard has more than 15 years of experience in clinical nutrition and obesity. Prior to joining the faculty at Wake Forest in 2012, Dr. Ard spent 9 years at the University of Alabama at Birmingham, where he served as medical director of UAB's Eat Right Weight Management Services, vice chair for clinical care in the Department of Nutrition Sciences, and associate dean for clinical affairs in the School of Health Professions. Dr. Ard's research interests include clinical management of obesity and strategies to improve cardiometabolic risk using lifestyle modification. He has been conducting research on lifestyle modification since 1995 and has worked on several National Institutes of Health-funded medical multi-center trials, including dietary approaches to stop hypertension, DASH sodium, and weight loss maintenance trials. His work has been published in numerous scientific journals, and he has been a featured presenter at several conferences and workshops dealing with obesity. Dr. Ard has also served on several expert panels and advisory boards, including the Institute of Medicine Committee on Consequences of Sodium Reduction in Populations, the NIH Expert Panel on Identification, Evaluation, and Treatment of Overweight and Obesity in Adults, and the American Psychological Association Obesity Guideline Development Panel. Dr. Ard, I would now invite you to proceed.
Thank you, Sheldon. I appreciate the opportunity, and good afternoon to those who are joining the webinar today. what I want to do is spend the next 45 minutes or so talking about obesity disparities and uh, providing a little bit of context around the factors that may be associated with those disparities, because I think that then helps us frame how we look at the treatment options for obesity. And then what I want to do is finish this up and really sort of tie this back into type 2 diabetes with some different ways of thinking about type 2 diabetes and obesity treatment in hopes of challenging people to really sort of think about how we might change the paradigm to get a better handle on what is now not just an obesity epidemic, but a type 2 diabetes epidemic as well. So let's jump right in. I think as most people who might be interested in this topic would understand, we have a significant increase in the prevalence of obesity in the US and globally. And in particular, it is affecting individuals of color disproportionately. So you can see from the late 80s to early 90s in the blue bars, prevalence of obesity, and you see the increase in that prevalence of obesity over time. The graphic on the left is for men, and the graphic on the right is for women. So you can see there is a difference by sex in terms of the proportion of individuals who are dealing with obesity, with it having much more of a prominent effect for Black women compared to Black men. And during the same time frame, we're also seeing an increase in the prevalence of diabetes, type 2 diabetes. And there's a clear link between the two. 87.5% of those who have type 2 diabetes also have overweight or obesity, and 43.5% have stage 1 to stage 2 obesity with a BMI of 30 to 39.9, and then nearly 18% of individuals with type 2 diabetes have a BMI of 40 and greater. And this is just a graphic depiction of that change over time. So you can see obesity prevalence on the x-axis and diabetes prevalence on the y-axis, and each one of these dots, these circles, actually represents a state in the U.S. During the given time period, and you can see that as the prevalence of obesity has increased over this time frame from 94 to 2012, that the proportion of people with diabetes is growing, and the population of people with diabetes is represented by the size of those circles, and that the size of those circles is growing over time. And as associated with that is a disparity in the prevalence of type 2 diabetes by race, and we can see that individuals who are Black, non-Hispanic, those of Hispanic origin, and American Indian, Alaskan Natives, all have higher prevalences of type 2 diabetes. For Black women in particular, you're talking about nearly double the prevalence of type 2 diabetes compared to non-Hispanic white women. So the question is, why do we see this level of disparity by race when you look at even combining overweight plus obesity in Black women? In particular, 82% are dealing with overweight or obesity. Why is that disparity there by race? We all understand race is really just a social construct. There are no biologic characteristics that are inherent in racial categories. But we can't deny that race has significant associations and implications for health in the U.S. because of our history. And a lot of what we've seen is that issues related to social class often co-segregate with race, and cultural identity also has a significant influence on body weight, and that has some associated health impacts as well. So when we start to think about some of these sort of commingling of issues around social cultural and social cultural identity and social class, it's hard to untangle those in a lot of instances because we might understand that for lots of diseases, things like race and education, income and education can be protective against an increased risk of a certain disease. Well, in these two graphics, you see from data from the CDC that attainment of education or higher income categories are not necessarily protective for Black women in the same relationship that holds in the same way that it holds for white women. So as educational attainment goes up for white women in the pink bars, you see that the prevalence of obesity is lower, whereas across the board it's fairly consistent for Black women. And then as income goes up, typically in the highest income category, you see some protective effect for white women or association with that. But that is not quite the case for Black women. So this is where we might say some of the cultural beliefs and attitudes might override such effects of educational attainment and income category, where social class might change, but personal identification and cultural identification may not change, and that may override some of those types of associated differences. And just as a way to sort of think through this, race may really be a marker for some other factors that are now just segregating in ethnic enclaves. And so if we think about the prevalence of a disease as really being affected by a combination of factors, especially a complex disease like obesity, there are several genetic underlying risks that may be relevant, but we also understand that environment has an impact in terms of interacting with genes and including key exposures. And then individual behaviors may either mitigate or enhance that risk in terms of personal choices. But all of those things are influenced by the other components. And so what we may see in terms of race is that because those things like your environment, where you live, the neighborhood you live, the amount of education you attain, those types of things are so closely associated with race. In the US, we see this sort of clustering effect. And that then becomes a reason or part of a reason why we see this significant disparity in certain groups of the population, like African American women, for example. So if we start to put those things together and sort of try to put together a plausible reason for something that might explain some of the variability in weight and BMI, just for one simple example at a very high level, we have some evidence that African American women might have a lower resting energy expenditure per unit of lean mass. And if you combine that with the fact that African American women may be more likely to live in neighborhoods that have a higher proportion of fast food restaurants versus other types of food outlets, that's going to have an impact on marketing and exposure to lower quality, higher energy dense, poor nutritive foods. And then combine that with individual ideas about body image that may be different from the mainstream, that don't necessarily promote a drive for thinness, then you can see how the combination of those factors might systematically lead to attainment of and or maintenance of a higher body weight. So I'll just give you a few examples of things that people may be well aware of or maybe haven't thought about in terms of just evidence of or supporting the idea that, yes, people do think differently about body weight, and that then has an influence on individual behaviors and choices. And that some of that may be tied to sort of individual cultural identity or perception of oneself relative to race. So this was from several years ago now, when Dr. Regina Benjamin was Surgeon General. she made a comment in the New York Times article about the impact of hair care on Black women in particular, sort of being engaged in physical activity. And her quote was, oftentimes you get women saying, I can't exercise today because I don't want to sweat my hair back or get my hair wet. And that has a significant impact because there are other barriers that we often talk about in terms of green space and so forth and so on, safe places to exercise. But even in the situation where you have access and you have the capability to be physically active, you still have other barriers that may be unique to Black women that, again, as a Black man who, as you saw in the picture in the beginning, I don't have hair care issues. That's not going to be an issue for me. I can go out and exercise whenever I want, and my hair care routine is fairly simple. So for someone who doesn't have that benefit or lack of benefit, if you want to call it that, like myself, then that's going to be another consideration. And it's not that it's something that can't be overcome, but it is certainly a consideration and is important to the individual. Here are a couple of other examples. So we did a project, a research study several years back where we asked white and Black women separately, how does your race, how does being a white woman, for example, affect your weight? And we gathered those responses and submitted that to a card sorting task and asked women to rank those responses. And the types of responses we got from white women were typically things that were related to an idea of pursuing thinness, or cultural environment, or general sort of network of friends and family who were supportive of or pushing for thinness. And so responses around distorted expectations of a perfect body type. We heard lots of comments related to the idea that I need to look like a Barbie doll. And that was my idol or my image of what beauty looked like. Success depends on being thin and looking beautiful. Having negative body images, having a standard for ideal body shape that is thin. Those are the types of responses that white women provided and ranked highly in terms of being important to them. Compare that to what Black women said when we asked the question, how does your race affect your weight? They talked about things that were in a polar opposite direction in terms of being permissive of weight gain or supportive of weight gain, and actually having to work hard not to gain weight. So thinking about in their sort of day-to-day life, dealing with a lot of unhealthy food preparation, what they call the traditional Southern diet, poor food selection habits related to that, a general lack of exercise, understanding that chronic disease and medical costs are related to their weight, and just the fact that they are African American. Not having enough education on how to eat healthy, and stress that led to overeating, multiple roles. Many talked about playing multiple roles both at home and in their communities and at work, and how that can be overwhelming and then lead to less time for self-care. So the types of responses that you see for these two groups of women who geographically come from the same area, but identify differently based on race, based on self-identified race, really polar opposite types of responses in terms of thinking about how their race affects their weight. And then the other thing that I don't think that we talk about as much in this space is really how the health system influences obesity prevalence and, interacts with an African American patient to either increase the probability of not seeking treatment or not being able to access treatment, or even discussing the idea of obesity. So this is a really interesting study from 2011 looked at are people being talked to about the idea that they might have obesity, and in an encounter with their primary care physician. And so one of the things that really sort of stands out to me is that in general, people are African Americans are less likely to be told that they have obesity, and that number goes up, so that the odds of not having a conversation about obesity and overweight, actually the odds go down when the BMI goes up. So it's really, it should be the other way around. We should be seeing higher odds ratios of, much higher as the BMI goes up, because that means that the individual is obviously already in a category of risk, has the disease, and we're not seeing that individual physicians are endorsing that or talking about that. And we also know that healthcare provider endorsement of a weight control treatment can actually have a positive impact on weight management behaviors. People are more likely to seek treatment when they have a positive endorsement from their provider. So when you start to look at that African Americans are less likely to be less likely to have those discussions with their healthcare provider, and combine that with the idea that African Americans may be less likely to associate health risk like cancer with excess body weight, what that tends to do is just reinforce the idea that, well, as long as I feel and look healthy and my family and friends feel that I am a vibrant person, then I'm okay. And so that potentially has an impact in terms of, not engaging in treatment. Certainly, if someone engages in treatment, they may do so later in the course of the disease. So now they're presenting with more severe obesity, and that might lead to an increased length of time of being exposed to that disease state, leads to the increased probability of developing comorbidities like sleep apnea, hypertension, type 2 diabetes, etc. So if we want to just sort of sum up that first part there, I mean, what we know is there's an increasing prevalence of obesity, and that's related to diabetes, which is also increasing in prevalence. There are certainly disparities in obesity and diabetes for African Americans, and that's probably due to a lot of factors, some of which can include socio-cultural factors all the way to our health systems and the players within the health system in terms of not engaging patients in treatment. And so if we can understand that context, then that might help us sort of understand and frame how we think about response to treatment. So let's move into thinking about treatment and what we should expect from obesity treatment in populations of patients who are African American. So this is a very critical sort of rubric here, because it just sort of lays out very clearly, I think, that behavior modification is the fundamental sort of cornerstone of what we're trying to do. And we're using pharmacotherapy and surgery and other tools in the environment, as well as social support and networks to sort of help the individual engage in that behavior modification. So those other tools are essentially helping to improve the probability that someone is able to implement a low-calorie diet and increase their physical activity to be effective. And at the end of the day, what we want to do is create a sustained energy deficit so that we're burning more calories than we're consuming, and that's going to lead to weight loss. And so ultimately, the primary tactic that people are going to have access to is consuming fewer calories. There are ways to absorb fewer calories through medication or a certain type of surgery, but generally speaking, no matter what we're doing, it's starting out with consuming fewer calories, increasing physical activity, increased energy expenditure. And so when we think about the types of general effects that we get along this continuum of escalating therapies, lifestyle modification, we can see results that are clinically meaningful in the range of 3 to 10% of initial body weight in terms of weight loss that's achieved. Pharmacotherapy plus lifestyle modification can lead to weight losses in the 5 to 12% range. So some overlap with the lifestyle modification one of the things that pharmacotherapy does, though, is it really increases the proportion of people who actually respond to treatment, and that's not necessarily something that would be called out in just in terms of the percentage of weight loss that's achieved, but you might see that with lifestyle modification alone, about 45 to 50% of people might lose 5% of their weight. With pharmacotherapy plus lifestyle modification, those numbers can go up to 75 to 80% of people who are achieving clinically meaningful weight loss. And then you have surgical procedures and techniques. Gastric band is not being done as much in the U.S. Sleeve gastrectomy is being done much more often these days. About 59% of the cases that are being done are sleeve gastrectomy. And gastric bypass is really sort of the mainstay in terms of anchor of what we think of bariatric surgery. But sleeve gastrectomy will typically get you about 25 to 27% weight loss versus a gastric bypass, which is about 32% weight loss of initial body weight. So if we think about some of the things that we know in terms of how these different strategies impact African American weight loss, there are a couple of different things that we can look at and summarize. So this is a review of 7 NIH-funded multi-center trials from the 90s to 2012 that included things like DPP, the Premier study, TONE, hypertension prevention trials, several classic trials. And in those trials, typically what you saw is an intervention strategy that was all behavioral, so very well thought out behavioral techniques and strategies, typically involving group therapy, group engagement with trained interventionists. And the typical weight loss for African Americans is usually somewhere in the order of a couple percentage points lower than what you might see for the same Caucasian person in that similar clinical trial. But what you also notice is that African Americans usually after that 6-month period of time have less weight regain generally, or just a similar amount of weight regain. So they don't, we don't see that African Americans regain weight at a different pace, and sometimes it's actually better maintenance of weight loss that African Americans experience. You see similar reductions in terms of blood pressure. Actually, in 3 of the 4 trials, only one trial, the Premier trial, actually did not show any significant blood pressure reduction for African American women. And then in the diabetes prevention program, there were actually no differences in diabetes incidence, even though African Americans lost slightly less weight than non-African Americans in that trial. But again, they were able to maintain the weight loss slightly better. There's actually been very little study of effects of pharmacotherapy by race. This is one study that was done with liraglutide 3 milligrams. It's a GLP-1 receptor antagonist or agonist, and this analysis is from the SCALE studies of liraglutide, and essentially shows that there really is no interaction between treatment and race for these groups. And you can see the percent weight loss for whites on study was 7.7% versus 6.3% for African Americans. The subtracted placebo estimated treatment difference then is 5.3%, which you would attribute to the drug for whites, and 4.8% for blacks, African Americans. And so those are not statistically different, that 0.5% difference. So this is really interesting in that you see a similar treatment response to this particular pharmacotherapy strategy. But there are several other pharmacotherapy strategy drugs that are available in the U.S. approved for long-term treatment of obesity, but very few. Actually, this is the only study that I know of that has actually looked at treatment response by race. And then to think about sort of finishing up the treatment pyramid, if we look at surgical treatment response, surgical treatment responses by race has actually had a fair amount of analysis and data reviewed. And there have been several fairly consistent reports over time that show that African Americans tend to have a slightly lower excess weight loss compared to whites. And in the early sort of goings or sort of increasing popularity of bariatric surgery from the late 90s to the mid 2000s, there was a report that looked at mortality rates by race and saw that African Americans were having slightly higher but significant increases in or slightly higher and significant mortality rates compared to blacks. And it was particularly pronounced among males and those who were going to hospitals that maybe didn't have an experience as an experienced surgeon. And so one would expect that those numbers would potentially change over time as we see an increase in things like centers of excellence and increasing volumes of cases in, various hospitals, community hospitals in particular. There are also, as a part of that analysis or another analysis, looking at the number of readmissions to the hospital. So this is a really big outcome that people look at within 30 days of having surgery. Are you likely to be readmitted to the hospital during that 1 month post-operative period? Because then that indicates that there is something that fundamentally has not gone well with the surgery. And so in this particular analysis of about 50,000 patients, African Americans were much more likely to be readmitted to the hospital within 30 days compared to non-African Americans. And so this recent study was published from Michigan that looked at a more recent cohort from 2006 to 2018 of 14,000 patients in that area. And what you still see at this point is that African Americans are still having slightly higher rates of complications and readmissions, along with greater length of stay in emergency department visits post-operatively. So, it suggests that there is still something different that's occurring, even though we have people who have more experience and comfort with the procedures, and we're using more laparoscopic procedures instead of open procedures. There's still something that's happening differently in terms of the healthcare experience for African American patients who are undergoing bariatric surgery. But similar to what we saw in the data around behavior and behavioral lifestyle intervention and changes in risk factors, you see that even with a slightly lower amount of weight loss, in this graphic on the right-hand side here shows that African Americans are losing about 5% less body weight, 4 to 5% less in terms of total body weight for any given procedure. You're still seeing similar amounts of remission or higher amounts of remission of diseases like sleep apnea and reflux, no difference in remission of type 2 diabetes, which is very important, but lower remission of hypertension. So there's definitely something positive for African Americans to be thinking about when it comes to bariatric surgery, but there's still some challenges in terms of complication rates and some of the issues that may be happening post-operatively. So when you think about the process of going from healthy weight to weight gain and diagnosis with obesity to seeking treatment to actually trying to engage in treatment, there are several points along that way where disparities exist, both in terms of access to care, the environment, and then the potential outcomes. And that could be related to lots of different things that are along that pathway. So we have to be able to think about the influence of all of those things as people are in this process of trying to seek access to treatment, as well as then once they've engaged in treatment, really trying to maximize their response to said treatment. So if we just summarize that section on treatment, I think it's fair to say we have a range of effective treatment options for obesity, but African Americans may be less likely to pursue certain treatments. There are certainly studies that have shown that for the prevalence of obesity, the number of African Americans who are pursuing certain types of treatments like bariatric surgery is definitely underrepresented based on the population prevalence of obesity. And that could be due to a number of different things in terms of access to good health care, but also ideas and thoughts about whether or not you want to engage in intensive treatment like bariatric surgery. We also saw that African Americans may not lose as much weight as non-African Americans for a given strategy, but disease modification and risk factor control looks to be similar. So the amount of weight loss may not have to be as high, but in order to get the same benefit and comorbid control as some other groups. And I think there's still a lot that we need to learn both about surgical treatment strategies and pharmacotherapy in Black populations, because those tools should be utilized more, should be a part of the spectrum of care. And if we're not offering those types of tools, if we're not understanding those types of tools, we may be losing out on opportunities to really start to change how we think about disease modification and control. And let me use the idea of diabetes as a way to illustrate that. So why does this matter when it comes to type 2 diabetes? In the past, we've really talked about diabetes objectives as really focusing on control and prevention of end organ damage, right? So if I keep my hemoglobin A1C less than 7, then I can decrease the probability of me having end-stage renal disease or neuropathy or retinopathy leading to blindness, those types of things. So that's been the objective, is let's control it. We know it's a progressive disease, and you may need to be on more medicine over time and ultimately end up on insulin, but we can still control it. Well, I think these days we actually should be thinking more about remission and complete avoidance of dysglycemia, so that we take people who have crossed that threshold from pre-diabetes to type 2 diabetes and actually say, okay, we're not just going to be okay with the idea of just simply controlling it and letting you progress down the road over time. We actually can look to move that back into a normal glycemic state, get rid of type 2 diabetes, put it into remission. And what do we mean by that? That's basically a normal blood glucose level without any type of pharmacologic therapy. So someone who's got a normal blood glucose goes from someone who has type 2 diabetes, and let's say they had an A1C of 7, and on two medications, they lose sufficient weight, change their diet, physical activity, get to a point where their hemoglobin A1C is now less than 5.7. They're on no medication. That's what we consider remission. And then there are other definitions that include a certain amount of time and duration for that. But what do we need in order to be able to get people to remission? Well, we know from the recent research that we have that both bariatric surgery and lifestyle modification, lifestyle interventions can lead to diabetes remission. And really the target is somewhere north of 15% weight loss. We can achieve weight loss that's in that range and higher, then we increase the probability that people are able to achieve diabetes remission. So I'll show you just briefly some of that data, and then we'll finish up here. So diabetes remission in bariatric surgery, the average amount of time or median disease-free time following Roux-en-Y gastric bypass is about 8 years. So people who have type 2 diabetes have Roux-en-Y gastric bypass, they are typically taken off most of their medication very shortly thereafter or the day after they have surgery. And those individuals can maintain normal blood glucose for a median of 8 years. And so that's really important in terms of, you know, that amount of time that they're not using additional resources for medical care related to diabetes. They're not having to deal with risk of hyperglycemia, hypoglycemia, those types of things. Predictors of that response are important. So younger age, shorter duration of diabetes. So that means that we should be getting to people earlier, not on insulin. So if you're already on insulin, then the probability that this is going to lead to a durable remission is lower, starts to go down. And people who lose more weight. The people who lose more weight following bariatric surgery generally have a greater response in terms of diabetes remission. Here's an example of a clinical trial that was done to look at diabetes remission over 5 years when we compare medical therapy versus sleeve gastrectomy versus Roux-en-Y gastric bypass. And what you see in the pink here is that Roux-en-Y sleeve gastrectomy leads to remission rate at about 3 years of about 29% and 23% at 5 years. For Roux-en-Y gastric bypass, you see significantly higher numbers, 46% at 3 years and 30.6% at 5 years. And this is from the Stampede trial. So it's one of the few actually randomized controlled trials that we have comparing these surgical procedures and really having a very strict definition of type 2 diabetes remission. We actually also saw in the Look Ahead study a report related to diabetes remission and showed that in the intensive lifestyle intervention group, about 12% of people in that first year were actually able to lose enough weight to achieve diabetes remission. And a large percentage of those individuals were able to maintain remission over 4 years. So ended up about 7% of individuals at 4 years were able to maintain diabetes remission. So this is really interesting and led to a lot of additional considerations of, well, okay, if an intensive lifestyle intervention can lead to diabetes remission, what if we put together a strategy that really sort of drives at the idea of getting people to lose about 15 kilograms or 15% of their body weight? And so this trial out of the UK called the DIRECT trial actually tested this hypothesis that getting people to lose about 15% of their weight will lead to significant reductions in or lead to a significant remission of type 2 diabetes. And so they define that as basically having a hemoglobin A1C less than 6.5 and being off the diabetes meds for at least 2 months consecutively. And so 46% of people who are in the intervention group achieved remission. 86% of those who lost 15 kilograms achieved remission. So again, that number of about 15% or so is really important in terms of being able to increase the probability of type 2 diabetes remission. And the average weight loss at 1 year for the entire intervention group was about 10 kilograms. So again, this is on the order of the 10% or higher amount of weight loss that's necessary to achieve this. And this was done out of primary care offices in the UK. So to finish up here, I think what I'm trying to make the point around is that diabetes remission is actually the new target, or should be the new target, for how we think about managing type 2 diabetes as a consequence of obesity, given that there's such an overlap between obesity and type 2 diabetes. And that's achievable with intensive obesity treatment in the right patient population. So people who have recently diagnosed, people who are not on insulin already, individuals who are younger who get diabetes earlier in life, we need to be thinking about this. And a weight loss target of about 10 to 15 kilograms is likely going to be necessary in order to be able to achieve that. We do know that some surgical series have reported outcomes of diabetes remission and by race, and that there are no differences in that population of individuals who are doing bariatric surgery. We don't have any of those outcomes by race for intensive medical weight loss strategy. So the DIRECT trial, for example, was done in the UK, and they had no individuals of Black or African descent participating in that particular study. So we need some outcomes. We need to test whether or not this is going to be effective for individuals who are Black or African descent, and in particular in the U.S. We need to better understand this. But this is something that I think, as we sort of look at the bigger picture and think about all the types of things that we're thinking about related to diabetes control, it's starting to really change the paradigm and start to think about, well, should we be pushing for diabetes remission? And in order to be able to do that, we need to be able to improve access to care. We need to be able to think about how to make sure that treatment is equally effective. We need to ensure that treatments are safe. So if more people are going to do things like bariatric surgery, how do we ensure that those outcomes are going to be similar in terms of lower risk of adverse events and mortality? We also need to figure out how to get African Americans engaged in treatment earlier, and address barriers within the health system, and address the individual level factors and the environmental factors. And then ultimately, we have to understand how those social determinants impact people's response to treatment. So two people in different environments get the same treatment. What are the things that are going to be modifying that treatment response? And what are the things that we can easily manage to influence so that we improve the probability of a sustainable, durable response in terms of both weight control and things like diabetes and diabetes remission. So I think that concludes all I have to say. We'll stop here and see if we've got questions. Turn it back over to Sheldon.
Certainly. Thank you so much, Dr. Ard, for that insightful and interesting presentation, and your perspective on really shifting the paradigm in terms of what we're looking for in terms of managing diabetes risk in these populations, looking for remission as opposed to just management of disease. I'd like to invite any of our participants to post questions now using the Q&A button in the Zoom webinar interface. And we do have a few questions, but I do invite the rest of the audience, if you do have any questions, please post them there, and I will post them to Dr. Ard. So our first question is basically, is the lower resting energy expenditure, and I think this was on a slide that you presented earlier, amongst African American women due to a lower rate of fatty acid oxidation per same level of body mass?
Yeah, so that's a good question. I think an important question. I think that what we understand about that is that lower resting energy expenditure may be linked to improved or differences in energy efficiency in terms of skeletal muscle. So the lean muscle mass accounts for 60% of our total, resting energy expenditure, and African Americans tend to have greater energy efficiency, and so I think as a result of that, you don't have to burn as many calories to do the same amount of work, both at rest or active. There are differences in fatty acid oxidation in terms of what we call metabolic flexibility. So African Americans are less likely to shift to burning fats when in the setting of or in the face of a high fat intake. But that, I don't know that has a direct influence on the overall resting energy expenditure. I think it's more related to the muscle mass and energy efficiency with lean muscle.
Okay. We have another question. I think this relates to your previous slide where you had talked about some of the difference in the prevalence of obesity compared to between African American women and Black women, and looking at some of those kind of, I guess, external or demographic factors in terms of education, in terms of income. Could you say a little bit more, maybe talk about why those characteristics like education and income may not confer a similar protective effect on Black women compared to white women? Is this environmental or cultural?
Yeah, so I I call this the keeping it real effect, right? So it's the idea that even though my social status has changed, my class might have changed. So I've gotten my college degree. I have a good paying job, and I don't have to live in the neighborhood that I used to live in, and I can shop in a different store and so forth and so on. But my cultural identity still is kind of the anchor for how I think about the world and my framework, and so that overrides the um, decisions that or that influences the decisions I make in terms of behaviors and choices and how I engage with the world. Because if I don't identify certain behaviors or routines or foods, for example, as being part of my cultural norm, even though I might have access to them, I still won't choose them.
Sure.
And that I think is the difference between that effect that might happen for, say, someone who is Caucasian and they improve their status in terms of social class. Um, their identity doesn't say that. Well, hey, I shouldn't eat asparagus because that's not what white people do.
Hmm.
Um, whereas someone who says grew up African American and really sort of identifies with that particular way of life in terms of cultural norms may say, yeah, those types of foods are not the types of things that I grew up with, and so that's foreign to me. And so even though I could buy it, that's not something that I'm going to buy. Um, and then some of those things don't change regardless of education and income. So if we go back to the hair example, right? Yeah, I mean, someone who wants to exercise has to make that choice of, well, how do I manage my hair care? And yes, I fundamentally know and understand that exercise is a good thing, but and I might have the resources to be able to cover the expense related to getting my hair done on a regular basis. But is that something that I want to spend my money on? Is that a choice that I want to make? That's an extra burden. That's an extra expense. And so it may override the knowledge and income effect because of those sort of fundamental identity issues.
Hmm. Certainly. So a couple of people actually raised their hands, and unfortunately, we were not going to be able to open up the presentation to allow people to ask questions. But if you do have a question, please do use the Q&A button. We have some more time, and we certainly have some more questions. So the next question is, what are the optimal levels of macronutrient intake for weight loss among African Americans? Or is it just lowering calories independent of where the calories come from?
So, my general philosophy about dietary strategy for weight loss is really all about understanding the individual, um, both their environmental context, their behavioral context, and characteristics, as well as metabolically what makes sense for them. So I can't really say that we know that, for this population, it's this dietary pattern. I think there's lots of variation and variability within the population. And so our treatment approaches tend to work at the individual level to say, for this person, a lower carbohydrate intake might be really appropriate because they have, very clear insulin resistance and elevated blood glucose and so forth. This other person may have hypertension, but no other evidence of a very elevated, blood glucose or insulin level, and they may have gotten to their respective body mass index by different pathways. So we're going to individualize that treatment plan. And so the person with hypertension might get the DASH diet at a lower calorie intake versus someone who might get a more of a Mediterranean style of treatment plan versus a lower carbohydrate treatment plan. And all of that may vary, again, based on the individual that we have in front of us.
And if we're thinking from a population perspective, is creating opportunities for people to make more healthful choices so that they can achieve those optimal levels of calorie intake on a much easier basis.
Yeah, so ultimately, you're right. I mean, at the end of the day, it does matter about the total calories, and if we're consuming too many calories, that's going to lead to a propensity towards weight gain. And then the quality of those calories, where are they coming from? Are they coming from highly refined grains and sugar, added sugars, and lots of processed foods versus more optimal food choices that are simply done and prepared, right portions, those types of things. So all of those things go into the mix. But yeah, at the end of the day, calories matter.
Calories matter, and nutrient dense, obviously, calories are going to be more.
Yes.
So we have another question, and this may be our last question. Thanks for an excellent review of these issues. From what you say, a critical set of research questions relate to how to help people who have successfully completed a type of obesity treatment or weight loss program to maintain that weight loss outside of clinical settings. Do we have any leads as to how we do that? No trial or program is going to last indefinitely, and environments will promote regain.
Yeah, so this is really an important issue, and I'm glad you brought that up. I think that the question, I would reframe that question, because I feel like what we need to do is help people maintain weight loss in the medical setting with medical help, because it's a chronic disease. And so we don't have the expectation that people with hypertension or type 2 diabetes manage their diabetes or high blood pressure without support. And so we need to build capacity. Yes, we need to have people trained, and we need to have support systems in place within the health system. But I do think that a long-term maintenance treatment plan is an important part of helping people maintain their weight loss. We do have some clinical trials, but not enough in the weight loss maintenance space to really sort of identify, okay, what are the other levers that we need to have in a community setting that might also augment what we could do in a clinical setting.
Certainly. And weight management is so complicated in and of itself, because you have so many different characteristics, so many factors included at the same time. So, kind of just stepping out of that picture and understanding the clinical component, and also, the lifestyle and the social component just as well.
Yes. And, you just take one simple sort of idea or example. Someone who lost weight at the age of 45, and they were premenopausal at the time, and they've been able to maintain their weight loss for 5 years, and then they go through menopause, their needs will change as a result of menopause, and they may now need some different type of treatment or support in a postmenopausal state. So just aging in and of itself is going to create some challenges for maintaining weight loss that we need to better understand.
Certainly. Well, I would like to thank you, Dr. Ard, for this insightful presentation and your perspective on obesity treatment in Black Americans. I would also like to thank our attendees today for participating in the Solutions to Diabetes in Black Americans webinar. We really appreciated your time, your attention. We will share an evaluation survey and video of this webinar shortly. We'd like everyone to have a pleasant and safe afternoon. I don't know if you'd like to make any closing remarks, Dr. Ard, before we shut down.
Well, I appreciate the opportunity to be here and share those thoughts, and I'm happy to connect with people offline. I'm on Twitter at Dr. Ard, and by email, jard@wakehealth.edu.
Thank you again.